Thank you.
Thank you, everyone, for coming. It's a real honor to present Dr. Evrard Nahimana, who is our Chief Medical Officer of Inshuti Buzima in Rwanda, Partners in Health Work in Rwanda. Many of you may know him because he's also a graduate of the Masters in Medical Science program in Global Health Delivery from this department. But I can tell you, I've worked with Evrard for a very long time. He coordinated Partners in Health's work in Karehe, which is a very large district, neighbors Burundi, and has had, from time to time, an influx of people fleeing the violence and the situation in Burundi, which was near and dear to Evrard's heart because he is a Burundian as well as a Rwandan. But what Evrard really, I think, fell in love with, and I saw that happening, is the notion of public sector accompaniment. He was far and away, with his compatriot Alice, the best accompagnators for the government of Rwanda at the district level, and did that work for a long time before overseeing the clinical work at CIH writ large. Also, he got very involved in the care of newborn babies and mothers and newborn babies, and really was a tireless advocate for raising the standard of care for newborns. And as many of you know, that has been a hugely neglected area in global health. And when Evrard first started doing work on this in Karehe, we had no NICU, a neonatal intensive care unit. Then we had a tiny neonatal intensive care unit that often had 17 or 18 babies in it, with about 4 beds, and now has a very large, very capable, excellent NICU. But more importantly than that, Evrard has worked on expanding good neonatal maternity care throughout Rwanda as part of a large multi-year grant, Saving Lives at Birth, and I was just happy to visit 2 weeks ago in a district that PIH hadn't otherwise been involved with, Ruli district, where we're seeing really dramatic declines in neonatal mortality and even maternal mortality based on some of Evrard's work. But that's not all. Today he's going to be talking about cancer. And as many of you know, I'm super happy to see Lydia. We have really the only significant cancer treatments in Rwanda in the Butaro hospital. It's part of the national system. Chris Brown has been a big supporter and others. And again, it's really about raising the standard of care, and Evrard has been working very closely with people, and we have seen people from 5 different countries, including one of our patients from Sierra Leone who was cured by the team, many people we know from Burundi, from Uganda, Tanzania, and Congo. So it's really amazing the work that's being done there, and we still have a long way to go. And so just last, I want to say that last week was the 40th anniversary of the famous Alma Ata conference. There were several of us there. Evrard was not there, but he was there with us in spirit. And sadly, very few people are talking about real aspirations for care for all. And I think what Evrard is going to be talking about today in his incredibly intellectual and incredibly also spiritual way is really raising the standard of care for everybody. So, Evrard.
Thank you so much. Hi, everyone. It's such an honor to be back here. I spent about 2 years here doing the Masters in Global Health. Then I went back to Rwanda. So it's such an honor to be back here and have this, share my experience with the cancer program. But just maybe before starting the presentation, I just want to say it's, in addition that just a presentation, it's also something that is on my heart because my mom was diagnosed with cancer at Butaro Center, and thank God she's okay, she's very free, she's totally recovered, and just want to say thank you to everybody. I know most of you are also involved in this initiative. So it'd be just to share my experience, but just want also to say that it's also a personal experience. So I just Butaro Cancer Center started back in 2012. And as most of you know, back in 1990, 2000, same with HIV, treating HIV for resource setting. People are saying it's not possible, it's very expensive, it's complicated, we need very specialized people to treat HIV. So cancer today is almost the same. People are saying it's too complicated to treat cancer in a very remote area in Africa. It's too expensive. It's not sustainable. So the same, story also applies to cancer, but many thanks to PIH and other people who are pushing and saying it's possible, and everyone deserves good quality of care. For HIV, for NCD, for mental health, for cancer, and for other diseases, for Ebola. Yeah. So the government and PIH back in 2012 said, let's move just beyond HIV, let's move beyond malaria, infectious disease, but also tackle cancer care. And we don't want only those who can afford, but everyone to have access to cancer care. So that's where the idea came. So far, from 2012, Butaro Cancer Care has been able to treat about 7,500 patients total up to now, from 2012 to 2015. So about 1,000 patients a year, and it's increasing. The more people are aware, treatment is available in Rwanda. We have more patients from Rwanda and outside Rwanda. So just the global context about cancer. Now that most of the cases are seen in developing countries, but we have an increasing number of patients with cancer in developed countries and low-income countries because of many factors. Cause detection, screening, diagnosis is still a challenge, but also vaccine for HPV vaccine, for example, cervical cancer, not yet available. So we are seeing an increasing number of cancer in low-income countries. So in Rwanda, yet we don't have a cancer register yet. So these are some of the data and estimation from WHO. For men and women, but also for female cancer, we still have a liver, prostate for men, and cervical cancer and breast cancer as the major, the most frequent cancer in Rwanda. Of course, this is Rwanda, but in the region, but also globally, I think the picture is not different from this. Also, one of the big steps that the government, in partnership with other institutions, made is about universal immunization for cervical cancer in Rwanda, in partnership with Merck. So this is very, very important. And so far, the government was able to give HPV vaccine to about 95% of the target population. I mean, the girls at school. So this is a symbol of partnership of government, public-private partnership. And we really, I think this could really help to increase the incidence of cervical cancer. But also to serve as an example, other countries will say, it's possible to make available this vaccine. So, that was the big picture, the global picture. So I want just now to talk specifically about the Butaro Cancer Center of Excellence. So PIH was invited in Rwanda in 2005 to tackle HIV and TB, and this was really a successful partnership. But then in 2012, that's where we said, let's go beyond just infectious disease and tackle cancer. So today we have Butaro Cancer Care providing basic imaging, pathology. We have a very good pathology lab. It's growing, even though we still have some challenges. We provide surgery, chemotherapy, and even though there is no radiotherapy unit in Butaro, we're able to partner with Nairobi Hospital to send and refer to transfer patients who need radiotherapy. So from 2012, we had to partner with many institutions in this noble mission of cancer care. So these are the main ones, Brigham and Women's Hospital, Dana-Farber, Dartmouth, Harvard Medical School, and University of Pennsylvania. They have been very, very supportive of this cancer program in Butaro, providing, supporting pathology, sending nurses, oncologists to provide, hands-on capacity building training on ground, but also provide ongoing support, from remotely, but also be able to travel to Rwanda to work with the team in Rwanda. Yeah, so as I was saying, today, Butaro Cancer Care of Excellence is able to provide basic imaging, pathology services, screening, consultation, outpatient and inpatient, chemotherapy, also send to Nairobi patients who need radiotherapy. So our patients comes from everywhere. Of course, the majority in Rwanda and in Burera district, where the hospital is located. But we also have patients from neighboring countries. These patients came from Sierra Leone, and thank you, Joya, for making that connection. So the child had a Hodgkin lymphoma, and he recovered totally in Butaro. So we work together with PIH Rwanda, and PIH Sierra Leone to bring bring him in Rwanda, in Butaro. So this is.
And he had radiation in Kenya, right?
Yes.
The globalist.
Yes.
Global cancer care.
Yeah. So I was saying most of the patients, of course, comes from Burera district, but we have, they also come from other districts in Rwanda. So what are some of the type of cancer treated in at Butaro Cancer Care? We have, of course, breast cancer, cervical cancer, ALL, and Hodgkin lymphoma. Those are, I would say, the main ones. But as you can see, we have, quite a large number of cancers we receive in Butaro. So you can see this is, the trend and the volume of patients received from 2012 to 2017. So it's, increasing over time. This is mainly because of the awareness in Rwanda and globally. I had my mom, as I mentioned, was diagnosed with cancer. She had that in Butaro, they treat cancer, and she came to visit me when I was in Rwanda, and we went there. They did biopsy. She had a thyroid, she has a goiter, and then they did biopsy, and they found she has a thyroid cancer, and she was treated there. So, we had to improve over time, both in terms of infrastructure, staffing, equipment, systems. One of the big expansion we made was to build an infusion center. So people who just need chemotherapy doesn't need to just stay for many time, just come for one day. We had a very, a separate building for infusion center. Patients just show up, have chemotherapy, and then go back home. So this is the infusion center has about 27 beds. We are also building a hostel for relatives. So because Butaro Center is located up in the north, and you can imagine people traveling from south going to Butaro, they need a place to stay. So we had to build a place for relatives where people can just stay with their relatives. So we try to be comprehensive, as much comprehensive as we can, to have the comprehensive care. We started with no oncologists. There's no oncologists back in 2012. So today we have 2 full oncologists. We just hired a new one. We have a pediatric oncologist and an adult oncologist. So, but at that time we had only nurses, technicians, general practitioners, also part-time doctors from US come to support the team. So now we are happy that the team has grown, and we have 2 full oncologists. These are local oncologists. One of is Burundian, but he's very happy to work with the team and support. So in the philosophy of providing not only cancer, but think about social determinants of health, we are very aware that most of the patients are very poor, so medication are not enough. So we had to have also a program called Right to Health Care to support patients for other needs, housing, school fees for their kids, help them for, some microfinance, to generate income. So the right to health care program is meant to support patients, moving from patients to producers. And we think it's also it's part of the cancer program. We shouldn't only separate and just provide medication. So, as you know, radiotherapy is very important, very key for cancer treatment. Unfortunately, we don't have radiotherapy unit in Rwanda. There's one that is being installed at a military hospital, but we had to send patients to Uganda first back in 2014, and then now we send patients to Nairobi. So we had to partner with some donors to, support the cost. So far, we've been able to send about 500 patients to Nairobi. And, I visited the Nairobi hospital and visited the patients 2 weeks ago. It shows us what is also possible. When we think about Butaro, we think it's great, it's something big. But when we travel to Nairobi and see, the quality of care, the level of infrastructure, the system, so we think, yes, we have a lot to do, but it inspires us even to do more. So the radiotherapy cost so far is about $4,000 per patient, but we are not. Yes, we are very conscious about the cost, but we are more inspired about the outcome when we send these patients to Nairobi. And we are now very happy that we'll have a unit in Rwanda, so the cost will go down for sure. So that's the right to health care program I talked about, to tackle some of the social determinants of health. So pathology lab is also a key component of the cancer care in Butaro, and with partnership with the American Society of Clinical Pathology and the Ministry of Health, we were able to set up a pathology lab. Now we have 2 full pathologists on the ground. They can do not only basic but more advanced, pathology services in Rwanda. Chemistry, but also do telepathology with either Dana-Farber or Dartmouth to be able to exchange experience and collaborate together. So we are very grateful about this partnership with American Society of Clinical Pathology. So research, again, very important, and thanks to Bethany and also the whole team who are supporting this. The team on the ground has been able to, do some research just to improve the quality of care. Nothing about clinical trial, but mainly to research directly, could impact and inform the work they are doing. I'll share maybe some of the publications that were done in Butaro. Mental health, again, a very important component. About 60% of the patients with cancer were also diagnosed with depression. So, we are very conscious about that. And part of the program, we also integrated a mental health program to not only tackle the mental health issue in general, but specifically for patients with cancer. So we have psychiatrists on the ground in Butaro, and also nurses have been trained to support patients with cancer. Electronic medical records. Again, we start slow, but now the whole cancer is equipped with electronic medical records, and both lab, inpatient, outpatient, billing. We have that system to not only document what they're doing, but also able to use that technology to document and improve the work they're doing. So, yes, this is Butaro Cancer Center. We start small, and we are very conscious about, we still have a long way to go. I tried to summarize, but we know we still have challenges in terms of staffing, equipment. The number of patients is increasing. The more people are aware of this center, we are receiving more people from Congo. We are receiving more people from Uganda. We are receiving more people from Rwanda, and this requires more staff, more drugs, chemotherapy drugs. Procurement of chemotherapy drugs is also another issue. We don't have experienced suppliers, vendors who could, reliable vendors who could provide those chemotherapy drugs. So we had to work with Boston to work with some international vendors. So it is what it is, with some consequences, cost, delay to ship those chemotherapy drugs, lab reagent for pathology lab. But we are very inspired by the work. We are so inspired by the outcome. I'll share some of the outcome. The survival rate for patients who have been treated in Butaro. But it's so inspiring to do this work. It shows at least it's possible. Even though we can save 1, 2, 3 patients, we know it's a noble mission. Myself, before I was more interested with newborn care, maternal child, but since my mom was treated in Butaro, I say, no matter what, whatever it takes, we'll do that. But then beyond just having a center, we know it's very important to create a system across Rwanda. So we are working with the government to see how we could create a network of hospitals for cancer care, but also follow up for patients who have been treated there. So if we receive patients, we treat them. They don't need to always come back to Butaro. We are thinking about creating some follow-up clinic, either in Kigali or other cities, so we can create sort of a network in the system. So that's our vision. That's how we are we're working with the government and other partners. So trying to do some analysis about our strengths and some of the opportunities and challenges. But again, as I mentioned, we are more interested about the opportunities and what we can achieve. Again, this, Butaro, cancer today, it's the same as HIV back in 1990s, where people are saying no, it's not possible to treat HIV. It's very expensive, but now we have universal care treatment. IOVs are available for free, so we're very conscious it's also possible for cancer. Yeah. Just want to highlight some of the, impact for patients. So, for Wilms tumor is one of the most frequent cancer for children, and so far we have been treated about 100 patients from 2012, and about 60% of children are disease-free. So this is so encouraging for us and inspiring. I know, when you compare to US, way more than that, but we think it's also inspiring for that to continue to do the work. Breast cancer, I would maybe give references so people can read about this publication. I won't maybe spend more time on that. So this is the survival rate for breast cancer. CML, 90% of patients are still alive, 75% hematologic remission, very important. Yeah, so these are some of the pictures, and my mom is there. Yeah. So I know in the room people have been involved in this program. So I want also this to be interactive, and I'll be happy to hear when people have been traveling to Butaro, provide support and or help in a way or another. So thank you so much for your attention, but also thank you so much for supporting this initiative. Thank you.
Thank you so much for the presentation. My name is Inshuti. I am in the program of health. So before now, I was in the region working for health physician, and I must say that I was involved in Mansare, was born to the Hodgkin's lymphoma. So on behalf of Monday and his family, and on behalf of Partners in Health, thank you people for the job done on them, because we have been dealing with Moses' issue, and it was very difficult. He had like a very big diagnosis. So I know Joy was involved, Paul was involved in transfer and initial medication for the oral chemotherapy in Sierra Leone. But then the oral chemotherapy reduced only a little bit of the neck, so he was out of school, so we have to transfer him to your clinic at Butaro. So he's back now, he's doing very well, he's in school, he's doing very well in school, and now he wants to be a doctor. And when we asked him why he wants to be a doctor, he says because he has seen so many people suffering as he did, and he also wants to help them as we have helped him. So he's now hopeful of life. So we're really very thankful of whatever you have done for him. So my question here is, do people have any connection with your patients in terms of following up on development? In Sierra Leone, we are kind of concerned about relapse. So I know we are supporting Monday, we are supporting his school fees. Now he's hopeful, his family is very hopeful of him. But then in case there is relapse, what are the initial steps? What are we supposed to be doing for him? You know, we have scheduled in 3 monthly checkups. We do his lab work every 3 months and see how he does. But we don't have any kind of protocol to kind of follow and see, what the necessary steps to do.
Yeah.
So in case you have any follow-up protocol, I would like to have and share with the team later.
Yeah. So far, follow-up. Rwanda is a small country. Follow-up has been a challenge, but in general, we don't have any issues with following patients. When you give them appointment, they will respect that. They will respect that, and keep in touch with our social program. They are always in contact with them. The issue is not really to go back to Rwanda, but rather when people are treated in Butaro and they feel, they will improve. They will become healthy. They will go back to school, or they will do their work. They say, I don't need to go back to Butaro. Now I'm okay. But in general, we don't have issues with follow-up. What we want to do is to work with community health workers. In Rwanda, we have a good network, a good program of community health workers. So we want to be able to work with them so that they can, reach them in their community. And every time when we send a patient, we also inform the community health workers or the nearest health center or hospital so that, they can also, follow that patient. Not only for cancer, but anything that may happen. So, yeah, I know in other countries it's a big problem. In Rwanda, we don't have really that because it's a small. You can reach wherever you want. You can call them. From maybe south to north, it will take maybe 3 hours. So for bigger countries, it might be a problem. But in Rwanda, because it's well structured, we don't have really that issue. The issue is mainly, those patients who say, I'm just okay. I don't need to go back. Yeah. But also, when we think about follow-up shouldn't always happen in Butaro. Then we think about how could we create other clinic and people can be transferred for follow-up in the nearest clinic. So create 3 or 4 follow-up clinics in Kigali, it's a big city, but also in the east, where we have a very dense area in terms of population. Yeah. So and again, the electronic medical records very important for follow-up to track back, kind of be proactive and as call patients using these electronic medical records. Yeah.
So kind of in line with a little bit of what you're talking there about systems for follow-up and also just systems for cancer care in general. I mean, about 10 million people live in Rwanda, or maybe a little more. And so do you ultimately see getting to a point where there's a need for these services in every district hospital, or do you think it can always be something more centralized than that?
Maybe I didn't mention that. So when we started this program, we also worked with the Ministry of Health to train general practitioners, nurses at the district hospital level. So diagnosis is and screening is conducted at the district hospital level and teaching hospital. So Butaro receives people and patients who already have a diagnosis, or maybe they suspect, but it's mainly for treatment and advanced treatment. But the say the primary work is done at the district hospital level. Yeah. So and then we have four teaching hospitals. They are also providing some of the cancer services. They have pathology lab, and 2 hospitals provide chemotherapy. Yeah, so we want to create that kind of network. So Butaro, maybe we started this, but we have also other facilities for providing cancer care.
Evrard, congratulations. This is a wonderful work. I think everybody recognizes that. It's a wonderful presentation.
Thank you.
A question I have to ask. So cancer care at its core for curative is usually best multidisciplinarily, chemotherapy, radiation, and surgical. I saw you had a slide for radiation therapy and chemotherapy, but you didn't tell us a lot about what the institution is thinking about how to approach the surgical aspects of care. You had a few points in there of selective surgery. Curious if you could fill us in on what Butaro Cancer Center is thinking about delivering surgical care as a component of multidisciplinary care.
Yeah, yes, surgery is also an important part. We, since last year, didn't have any surgeon at Butaro, but we knew it's an important component. So we had to either transfer patients who need surgery, particularly for breast cancer, to Kigali, where we have surgeons, but recently we have a permanent surgeon on site, and we're also planning to hire an additional surgeon so we can at least do some surgery related to cancer at Butaro. But so far, patients who need more advanced intervention, surgical intervention, we transfer them to Kigali. And again, we are very conscious it's a very important component. And we are now working with the Ministry of Health to have like a rotation program for surgeons. So we don't need, if you could have permanent surgeons in Butaro, that would be great. But we want to optimize those resources, few resources we have. The surgeons in Kigali could go to Butaro, spend maybe a couple weeks, months in Butaro, and go back to Kigali. Yeah.
Have you noticed any increase in awareness of in general cancer in the community once this program started in the I mean in the people, not in the health providers, but in general in the community, and how has that how did that help to reach more patients, or was that a challenge?
Yeah, as I mentioned, the volume of patients is increasing over time. Of course, there are a lot of platform forums to talk about cancer, meetings, conferences in Kigali, some education sessions conducted by community health workers, but also, experience of patients. So, yes, there is an increasing awareness of cancer in Rwanda, but I think it's not only in Rwanda but globally. So Yes, most of the patients, of course, they are from that area, Butaro area. You know, of course, they know, they've heard there's a center there, but also we are now having an increasing number of patients from Uganda, because Butaro is neighboring with Uganda, so have patients from Uganda also coming in, mainly because of the health system in Uganda is maybe not as strong as the one in Rwanda. Yeah, but there's definitely that awareness in the community. Yeah.
Can I do just a quick follow-up?
Uh-huh.
So thank you. Sorry. So thank you for your presentation and for your work. I just had a quick question. Can you tell us a little bit about palliative and end-of-life care?
Sorry?
About palliative and end-of-life care.
Oh, yeah. Palliative care. It's a big component, but also a big so we are doing some palliative care, very basic, and send patients home, but we want to plan and work with the community first, see how we can decentralize palliative care in district hospital. So, because the more we keep patients in Butaro, space is an issue. But we started a palliative care, very basic. I'm glad one of our staff very passionate about introducing palliative care in Butaro, but also create a network of palliative care centers in Rwanda. Yeah, but we know it's very important. Yeah.
My question. Thank you for your presentation. I've learned a lot for your very big work that you realize in Rwanda. And I'm Christophe. I'm working in Haiti. Mm-hmm. I'm the head of the OB/GYN department at University Hospital in Miambale. One problem that we face all the time is the flow of patients that we have is so high because we are the only hospital in the country that provides surgery for cervical cancer, surgery for ovarian cancer, and surgery for other cases, for the cancer cases. I'm wondering that it should be probably the same in Rwanda in terms of overflow of patients, and that's creates some things that we call that suffering from this patient because a lot of them sometimes die because they don't have time to get the surgery because we have a waiting list which is so high. And I would like to know in terms of managing this situation in Rwanda, how do you deal with that in a practical manner? Because maybe we can use from your experience to address so.
Yeah, that's very it's very important. So in Butaro District Hospital, in addition to cancer, they have to do other services to provide other care just because it's a district hospital. So one of the big issues is also space, how to, of course, provide cancer care, but also continue to do the routine work, infectious disease, maternal. So we have some criteria and try to discharge some patients to be able to have some space. But we are also planning to build a separate cancer building for inpatient adult and pediatric. The program will start very soon. That's one. But also, since some teaching hospitals started to provide some chemotherapy services in Kigali, we hope that over time we will see an increasing number of patients in Butaro because other centers are providing that that type of care. So, yeah.
The other question thank you. The other question is, and I see you provide care for cervical cancer, and if you provide, for example, chemo without radiation, or you provide, for example, you can provide chemo and surgery, but I'm wondering your program of surgery is a little bit not so developed, and also you don't have radiation. These patients you should send them elsewhere. I'm wondering how do you handle that? This is the first one. The second one is according to the nutrition program, linked also to cancer care program. How do you handle the nutritional aspect with cancer care and
Yeah, a big number of patients we sent to Nairobi, most of them, say maybe 60%, they need concurrent radio chemo. And, we can provide chemotherapy in Butaro, but we can't do radiotherapy. So we send them to Butaro, to Nairobi, where they can do both. So they are also able to do brachytherapy, brachy and radiotherapy at the same time. And the results are very promising. So the new unit of radiotherapy in Kigali, they won't have brachytherapy. It will be only radiotherapy. So we may continue to send patients to Nairobi because of the brachytherapy, and send some patients to Kigali for just radiotherapy.
It's just a comment. You can. Oh, you done your stuff?
No, it was a discussion, but I can keep.
I was going to have a comment about your strategy for overflowing of patients. So you said that you plan to have new building and so on.
Expand.
Yeah, but having the new building is something, but having the healthcare professionals work in that building is something else. So how do you plan to do that?
This work is not only PIH. So yes, PIH had started this initiative, but I have really to acknowledge the support we have from the Ministry of Health. Recently, more than 80% of the staff are paid by the government. More than 80%.
So it's a private-public partnership.
It's a public-private partnership.
Okay.
Recently, they appoint the oncologists, the adult oncologists I mentioned, who were very happy. So to see the government own some of the component, it's very encouraging. So. And they also have some plans. They have sent people to do oncology fellowship in Tanzania, in India. So now we have about 3 oncologist fellow Rwandans. So hopefully when they'll be back, they will continue.
Which hospital in India? Narayana?
I don't know exactly
My point was not actually the paying, but I mean, if you can have many buildings, but if you still have a few professionals, you will have people shared in all over the building, so it will be like, it's not which, I mean, the problem was changing because you will still have this kind of overflow. Because you have this professional who is working in this, so I think the increase of healthcare professionals is also
as I mentioned, we are very concerned about the challenges. Staffing is one issue. Space, the operational cost. But we know that's what should discourage us, but rather we are focusing on the patient outcome, and we know they deserve what they deserve. They deserve good quality of care. And most of the time, I remember when we started this program back in 2012, in Rwanda, even ourselves, we couldn't really believe, are we going really to be able to sustain this? Yes, we received like a big support from donors. It was at the beginning, people were very, excited about the project and provide money, but we were not sure about sustainability. But sustainability when you can save 1, 2, 3, 100 patients, that's more than sustainability, right? But also the enthusiasm and excitement that this has generated from partners, from government, from local leaders. I talked about expansion of the program.
Yeah.
The districts decide to give us a land to expand and have more buildings. It shows it's possible, and people join this initiative. So again, it's not only PIH. PIH, of course, we started this, but there are a lot of key stakeholders, governments, local leaders, community members, of course, partners, academic institutions. Soon we'll have, I didn't talk about that, but the University of Global Health will be located in Butaro. So we hope this also could, bring more support.
Thank you, Evrard. It was a wonderful presentation, and it's great to see you back. What do you think are the barriers of bringing radiotherapy to Butaro? Sounds like an amazing opportunity. What do you think are the barriers?
Yeah, it's we are that will be our next challenge, and we want to do that. But mainly cost. There are of course regulations around radiotherapy, but it's mainly cost, and we are very glad that we have a unit in Kigali. We want to be able to optimize this unit because in Kigali, now that we have a platform for screening, for treatment for chemo, we can easily use that and send patients to Kigali. There was a debate where they should send the radiotherapy in Butaro, but they ended up install the unit in Kigali, mainly because Kigali is centrally located almost in the middle, so everyone can travel easily to Kigali. But we are very conscious in this expansion plan, the master plan we have. There's a space for radiotherapy and more advanced imaging, CT scan, MRI. We recently received a big support from a U.S. company to design, to do a design for that expansion. So we are very excited for that. They will work with the local engineers, architects to build this. And this is a local initiative. The expansion, it will be a real joint partnership with the Ministry of Health and the local leaders and, of course, PIH.
Yes, hi, I just had a question. Thank you for a great presentation. Extremely inspiring. I know you addressed this before, the surgical aspect, but so we're writing a paper on the surgical aspect of the cancer management, and actually we saw that 4 out of 5 people with cancer will need surgical care, and less than 5% of people in LMICs receive a safe, timely, and affordable surgical cancer care. And so there's a great unmet need, obviously. So surgical care is like important in the entire spectrum of cancer management. So in your hospital, how does it look like? You mentioned that surgical care is seen as something more advanced, but actually, according to the Lancet Commission on Global Surgery, you've seen it's very cost effective. So I just wanted to see, how does it look at your hospitals, and what are your plans for the future? Because there is a great unmet need.
Yeah. Yes, surgery, I would say, is one of the less advanced components in Butaro. Only have one surgeon, and he's a general surgeon. When you're doing some breast cancer surgery, we hope we will be able to again partner with MOH, the Ministry of Health. I talked about the rotation for surgeons located in. Yeah. So we really hope that we could partner with some teaching hospitals in Kigali. That's where there's a big concentration of surgeons, so that they can travel to Butaro and do some surgery in Butaro. It's very challenging to have, some of these surgeons are, they're very low in the country. So moving them to Butaro, not an easy, but the idea was they can be full-time in Kigali and travel and do part-time with Butaro Cancer Center. Yeah. But also, I talked about task sharing, task shifting. Some of these surgeries can be performed by general surgeon or general practitioners. It's also possible. And we are also very cautious about that. We won't be able to have like a comprehensive team, a very specialized team in Butaro. It is what it is. But again, that's not the objective overall. We want to support the system. We want to build a system, a national system. If we could have, more centers in Kigali and other district hospitals to do that, that's good. That's in the end, we are saving Rwandan population.
I just have a follow-up question to that. I do think it's really interesting to think about, surgical care. You talk a lot about the surgeons that would be available, and I think we've seen through the data that a lot of these patients are referred to specialists in Kigali, which I think is the appropriate use of that expertise. But for the surgeries that are happening in Butaro, I imagine, and Lydia might have some information for breast cancer specifically, that you've seen an increase in the number of surgeries. So it's not just about having the surgeons there to do it, but it's also about the space, right? The infrastructure to do the pathology, the infrastructure to do then the surgeries that need to be done, to do the follow-up. So as you build the infusion for the cancer part of it, are we also building operating rooms for the surgical part of it?
Yeah. So far with the expansion plan, we will focus mainly on inpatient for cancer. So pediatric and adult, the operating theater and admission for post-operative will remain in the old building. So the plan will be first of all to start with the inpatient, and in the plan so far we have 2 operating rooms, in place with some standards, and they are not fully optimized. They are not fully used actually. If we could have 3-4 surgeons with the 2 operating rooms, I think infrastructure for surgery, I don't think it's the most important, like the priority and something urgent now. Staffing is, I think, the most important thing. Because with the 2 operating rooms, I think we can do more than we do now.
That staffing includes also sufficient and competent enough anesthesia providers to provide high level anesthesia care and pre-op and post-op nursing care and intra-op nursing care. So it's not just the surgeons.
Yeah,
the ecosystem.
The surgeon we have is always complaining, I need the 4 anesthetists. The more we bring new staff, maybe when we bring anesthetist, they will again ask more. But it's normal. It's normal. We are very conscious about that.
I'm a little bit concerned about only 2 operating rooms that you said. Do you take care of emergency surgery and only for cancer or emergency surgeries as well?
Yeah, both.
Because I wonder when you have C-section,
yeah,
a lot of surgery.
Yeah, that's happening at the district hospital. Yes.
It's not happening in the hospital.
Yeah. We actually most of the surgery mainly cesarean section.
But in the future, I would like to see your vision, I don't know, in terms of planning for upcoming 25 years, upcoming 20 years.
Please join.
Thank you. Yes, well, Evrard, thank you so much. This is excellent.